Thank you so much.
No worries.
Wonderful. Great lecture. Oh, what a way to end out this conference, this inaugural conference. Amazing. Our final speaker before we have the session concluded is Dr. Lyndon Cooper, and his topic is going to be full maxillary full arch restoration, choosing approaches for lifelong success. So there's no introduction required for him. He's just amazing, has been a mentor to a lot of us. So thank you so much for graciously accepting our invitation to lecture.
Well, good afternoon almost, right? It's tough to be the last speaker before lunch, but I'll try to do my best. Ollie and Mike, Dave, and Jordan, thank you very much for the kind invitation. I want to try to summarize some things, and we're going to go pretty quickly here. The title had the word choices in it. And you know, some of our choices are black and white in life and in dentistry, right? Pretty simple. But the problem is, choices often have unintended consequences, and we live in a very gray world. And I think that's where we are in most of implant dentistry. Patient comes into the clinic, terminal dentition. We start looking at the case as we do, get the information, create a wonderful plan, enthusiastic plan for this patient. And we know we can do great things. We have all the technology possible. And we send the patient home. A couple bumps along the way, but that's not bad for 3 hours work. And we went from teeth to no teeth very successfully. But then the concerns begin. The guided surgery didn't work. We had to retreat from that. Patient discovered to have uncontrolled type 2 diabetes mellitus. I discovered this much too late. Allergy to penicillin, we prescribed clindamycin. He didn't fill his prescription. I found out because 10 days after surgery, the pharmacist asked if I could confirm the prescription. At 7 days, he returned for evaluation with continual complaints and generalized maxillary pain and discomfort. This is what the radiograph looked like. I normally wouldn't take one this soon, but I was very concerned. This is what happened. It only took 2 weeks. We did a lot of things wrong. And technology will never save us from ourselves and from not knowing enough about what we're about to do for people or to people. We didn't get from no teeth to implants, did we? And if you talk to a lot of people, they'll tell you that they've had stories like this. Maybe not as dramatic. Maybe they lose a couple at a time, but we get there. And the truth is, we know better. We know that there's data that suggests that uncurled diabetics have delayed healing of dental implants. The problem was we didn't have the data before us. So what are my therapeutic goals, right? Success is going to depend on the choices I make. I want technical excellence. I want longevity of therapy. And I want to assure that the patient's therapeutic journey is smooth, comfortable, and enjoyable. In fact, at the end of the day, it's only if you believe in longevity and you realize dentistry is not perfect, it's only the therapeutic journey that becomes important. So what is the primary choice I have to make? It has to do with everything in planning. And I think planning requires a comprehensive diagnosis that involves a robust implant system to achieve the things you want to do. I won't go through this all, but you know, a comprehensive diagnosis requires anatomic information, biologic information, functional information, and understanding the patient's expectations and their abilities. And then we can come up with a robust technical plan. A robust implant system begins with something that promotes rapid osseointegration. It favors the maintenance and remodeling of peri-implant bone. It supports peri-implant mucosal health. And you've heard many people speak about this throughout the conference related to this implant system. It offers a resilient and strong implant abutment interface. And then where we haven't achieved greatness yet is we haven't figured out how we're going to facilitate repair. There is no universal abutment in the world. There is no universal implant abutment interface. And how do we support the care and feeding of an ailing implant? How do we promote regeneration? We'll get there one day. Now, I've been asked to speak about the maxilla, and it's a beast. The mandible, I'll teach my first-year dental students how to do a mandible. Maxillas, put on your big boy pants. Variability of anatomy, lower density of bone, demanding aesthetics, and the architecture of the maxilla is so unique from patient to patient, largely because those of us who have extracted teeth do things like take the buccal plate away, we remove a tuberosity with a third molar, all kinds of things, but we're never left with what we think or what we've seen in a textbook. Several years ago, we wrote a paper that said, you know, let's look at principles when we think about the maxilla: density, dimension, distribution, and display. If we focus on those four things, we'll always come up with a patient-specific treatment plan that's successful. When we think about density, we're concerned about primary stability, and implant design is just one of the factors and an important factor in achieving primary stability. Choosing the number of implants also helps us when we're in lower density bone. And so the question is, how many implants do we need? Well, that may differ from patient to patient or what you're trying to achieve. All-on-4 cases are great for my 70-year-old patients. Is an all-on-4 case good for a 21-year-old syndromic person who has no permanent teeth? I'll leave that question for us to discuss some other day. But when we think about the number of implants, we begin to also think about where the implants need to be placed. There are a lot of factors that affect the number of implants: patient preference, prosthetic material, opposing dentition, available space. All of these things begin to reflect the idea that we're creating a precision plan for each and every patient. Probably the most important factor that's overlooked in the maxilla is actually choosing the location of the implants. We've done a study that we've not published with short implants, and we learned that no matter what we did, we found that when we're planning maxillary implant cases, the distance between the most anterior and the most posterior implants was on average between 17 and 18 millimeters. And we decided that when you're planning a case, no matter how you plan it, it's the distribution of the anterior and posterior implants that becomes the key factor in planning for the maxilla. Now, there are 5 cases up here. The first in the middle is Brånemark's method, where everything went into pre-maxilla, and we've already learned that's really not a great way to work. You can choose all-on-4. You can graft the sinuses and place 6 implants posteriorly. You could be fortunate to have enough bone below the sinuses, use short implants posteriorly, and get great distribution. Or rarely, and on those optimistic days when you can smell the titanium in your office, there's enough place to put 6 parallel implants in the maxilla. Are they really that different? Because in the context of distribution, I've achieved the same goal 6 different ways, or 4 different ways. And we really need to be goal-oriented, not method-oriented. It's hard to argue that one or the other is substantially different from a biomechanical perspective, at least in a major way of thinking of things. And in fact, when you look at my experiences in implant dentistry over the years, they all look pretty well distributed, don't they? And these cases have stood the test of time. So we choose amongst opportunities. This is a case that was completed just a few years ago, and I had to ask myself, what's the best plan? Is this good? I like parallel implants. They're easy to restore. Short implants, I'm a big fan. But, got to go back one here. But 4 implants are really efficient. But I got to tell you, tilted implants and angled abutments aren't my favorite thing to restore. I'm lazy. I use them. I do it all the time. But is that the best plan? Or are they relatively equivalent? So we make choices based on anatomy, and we're often limited by bone volume in the horizontal or buccolingual direction, bone volume in the anterior-posterior dimension, or interocclusal space. And I'll take a minute to talk about each of these. When we think about horizontal deficiencies, that's a really great Panorex. That's a really deflating CBCT. But I've got lots of friends who are surgeons, and we can go through the process of harvesting tibial bone, expanding it with allograft or xenograft, and we can do wonderful horizontal grafting so that we can and sinus lifts and eventually place several implants. And we can go ahead and go through the process of building an FP1 type prosthesis with segmented zirconia restorations. We can achieve our goal. Took a long time. There's nothing immediate about this. And I would argue that for a 50-year-old person, this is a lot better than taking that vertical bone mass away and moving directly to zygomas. Although the thing with the zygomas is I'd have gotten there maybe 6 months sooner. Nonetheless, we're able to achieve a good result for this patient. In the anterior-posterior dimensions, we think about zones of bone, and Ed Bedrosian did a great job in saying, you know, we can talk about 3 zones, the premaxillary region, the region underneath the sinuses, and the posterior region of the maxilla. By the way, that posterior region of the maxilla is something my friend Stu Graves taught me about years ago when we talked about pterygoid implants, and something we don't spend a lot of time talking about today. But, you know, tilted implants is a way of dealing with the absence of significant posterior bone, but it gets us that anterior posterior dimension. It allows us to avoid dealing with the sinuses in any way, shape, or form. Short implants are something that I've been very interested in. We've done quite a bit of study on. In fact, a study involving, in a pilot study and following 31 cases, and they look like this, and they may concern you to see 4 6-millimeter implants hanging zirconia bridges versus a natural dentition or an implant dentition. But after 27 months of following these patients before I left the institution, we hadn't lost a single implant or a bridge. Now, I'll tell you something else about short implants before I go any further. I think they work great in healthy individuals. But you're sitting at the precipice of problems in bone remodeling and biomechanics. They don't work so well in patients who have underlying disease. And what about using sinus grafting, right? This patient clearly has no bone beneath their sinuses. But bilateral sinus augmentation was performed by my friend at North Carolina, Glenn Reside. And now you can see I've created 11, 12 millimeters of height, so we can go through a traditional procedure for segmented prosthesis, or at least an 8 implant prosthesis. And what we were able to do is demonstrate that we were able to place these 8 implants with great facility and optimism and build a beautiful zirconia prosthesis and deliver a remarkable outcome for someone who before the ideas of tilted implants or before the ideas of non-grafted solutions would not have had an alternative. So I believe that sinus grafting still has a major place in implant dentistry and allows us another alternative to treating the edentulous or soon-to-be edentulous maxilla. All the things I've said before don't cause many problems in implant dentistry. They just require us to make a choice. The restorative space or the occlusal gingival dimension, and the way you determine that is the biggest problem we have with the maxillary prosthesis. Because if you have a limited vertical dimension of occlusion or a limited vertical space for your restoration, you're going to end up placing a flange on your restoration. And then you're going to lose your implants at some point in the very near future, be that 5, 10, 20 years. So we really have to work very hard to determine this. And when we look at this, you've got to recognize you can't build anything with less than 13 millimeters from the crest of bone or 10 millimeters from the soft tissue. You've got to have that dimension. And when you think about things, you've got different types of patients, minimal resorption, significant resorption. We talk about FP1 and FP3 cases. Well, that's fine. And I think we should think about what the patient presents to us as opposed to the idea that everything is an FP3 case because someone might want that bone later on. You might need that, but it is an alternative. And the issue here is, again, getting that 13 millimeters of space. Now, when we talk about the different alternatives, you have FP1, FP2, and FP3, which Dr. Misch presented in his textbook years ago. FP1 and all those remarkable gingival architectures is a subtractive procedure. You're not growing papilla down, you're pushing pontics in. FP2 means you're going to make very long crowns. And FP3 means you're generally removing some bone to create enough space to have about 3 millimeters of prosthetic gingiva above those teeth. Sometimes it's simple. We begin by defining vertical dimension of occlusion, the midline and the occlusal plane, so we know how much space we have. We plan in our treatment planning software. In this case, the patient was going from an edentulous arch with a wonderful denture that would be converted. And we move through the situation of a simple guide here, right? 4 implants were placed. We picked up those the 4 temporary cylinders in our denture. We created this conversion prosthesis with no flanges and flat intaglio surfaces, and we delivered it for our patient to heal. 8 weeks later, we came back, took a quick impression, digitized it, made a full arch zirconia prosthesis for him. That's simple. Works every time. Simple. Happy patient. Sometimes it's not so simple. Sometimes it's complex. But again, we always begin by defining vertical dimension of occlusion and tooth display. And in this case, we realized we had a large maxilla. And if we were going to achieve anything, we were going to need to have a reduction in the height of the alveolar crest. Quite a major reduction. And you can use technology today to help you. It's not always necessary, but you can use what's called a stackable guide system where you have a basal guide, a reduction guide, an implant guide, and then a prosthetic guide all stacked onto each other. The basal guide is placed, we do the reduction. The implants then can be placed through the implant guide. And once the implant placement is achieved, we can attach the prosthetic guide and quickly pick up our cylinders. Now, you're buying about $3,000 of plastic. Do I advocate that this is the best thing to do? Not necessarily, but it shows us that we have a way of controlling what is needed to be accomplished. In this case, putting the teeth where they belong in the bone that is available. The tooth dimension and incisal display will define the extent of alveolar reduction. Now, when you take a look at this, do I have my 13 millimeters? In fact, it's just about 13 millimeters. And when the patient smiles, his tooth display is as anticipated. Now, this space is nothing trivial. In fact, this is where we run into trouble with prosthetic durability. You need space for strength. If you want a monolithic zirconia framework, you need 10 millimeters of zirconia, hopefully above the soft tissue. If you've got a titanium framework, it should be greater than 5 millimeters tall for longevity. And as Frank Lamar suggested, perhaps you might want to consider a cobalt chrome framework because then it doesn't need to be as tall. The modulus of elasticity of cobalt chrome is an order of magnitude greater than that of titanium. But I think one of the most important messages is that we need space for health. Even the small flange creates that type of a problem. Mike Block said to me, can you believe patients believe, or doctors believe they can cure this by telling patients to water pick their plaque away? Well, I've seen so much of this, it breaks my heart. And some of these stories are worse than what you see here. Sometimes flanges are 3 or 4 millimeters tall. It's just, we haven't planned. We put implants where the crest of bone was, not wondering where the restoration should be. So we can have no phalanges on a maxillary fixed prosthesis. Now, I put this picture up here to show you the process of going from teeth to no teeth to prosthetic dentition using stackable guides. But I want you to think about the power of this in reverse, because what you don't see in these 4 images is that the whole design began with determining where those 4 teeth, or where these 2 teeth needed to be. Once you know where the incisal edge position is, back here, you then understand how high the guide needs to be. It presents itself in a forward way, but it actually represents backward engineering. Because there's one other thing. If you design a case, you have to think about where the seam between the prosthesis and the natural tissue will be. And this is a rather extreme example that I have where a patient had a very high lip line, had a gummy smile, and we had to remove the teeth for implants. This required 7 or 8 millimeters of ostectomy to be able to actually hide the prosthetic seam. And you can see above it, the only thing that was left for us were short implants. And you'll see the line between the high lip line and the alveolar ridge is about 6 millimeters. It looked like this when we were finished. And the progression from pre-op to interim denture to conversion prosthesis to definitive prosthesis shows we are able actually to achieve our goal. If anyone tells this patient that the distance between her nose and her chin has gotten shorter, I will personally come and hunt you down because she never noticed. Another choice we have to make, and this is sometimes, we make really bad choices when we confine ourselves by saying, I'm going to immediately load something. I've been doing this for a long time. In fact, we published the first paper on immediate loading a mandible in extraction sockets way back in 1999. And Dave Felton was the chairman. He goes, don't hurt somebody. And Deb Sokla said, Dave, we got this. And we did a series of 10 patients and found out we could do this. And the more and more I do this, the less and less I do this, because I find out immediate loading makes you make bad choices. So we have lots of choices in loading protocols. Look at this patient, heavy smoker periodontitis. Do I want to transfer this biofilm, this disease, to my dental implants? I don't want to. You may want to. So we go through a period of edentulation. We make beautiful dentures. We have the advantage of determining where that incisal edge is. We can find out if he likes the smile he's going to have early in treatment. And then we can get to this. This part's easy, right? This is old school. This is something we did in 2011, and we were working with Enrico Steger and Zircon Zahn before it became the hot situation to be able to make these prostheses. And I got to tell you, there was nothing immediate about this. This patient went through a year of therapy. But I'm a prosthodontist, and I'm pretty confident I can make a good denture for somebody. And when you're a dentulist, the idea of an immediate kind of scratched my head. Like, you've been a dentulist for 10 years and you want to go from edentulation to implant-supported prosthesis overnight? What's wrong with 8 more weeks? Because now I don't have to do a conversion, and trust me, it's all about me. I'm getting the same money whether I'm converting it or not, right? That's like, you just go home for 8 weeks, you wear that denture. In fact, we'll do a 2-stage surgery so I don't even have to adjust your denture. That's really lazy. Took a long time to get here, right? And complex cases merit careful planning. Yeah, people are going to do this immediately, and they're going to show you how they do this, and they're going to tell you how great it is. And I'm going to tell you this is really hard. Because this is not about replacing teeth with implants. This is about changing someone's vertical dimension. This is about actually moving their jaw. This is about changing where they smile. And maybe this is not always just about all on 4 and always immediate loading, right? So in this situation, you really have to think about how far you have to go and how you're going to get there. I would like to test drive this. And we saw an example of this earlier where, you might argue that none of those teeth need to remain. And I would argue we have this wonderful advantage in prosthodontics that we can orthopedically or quasi-orthopedically move things around by, taking that bone away. I've got a friend who calls that 6 on the mountaintop, right? Those teeth have erupted because there was nothing else to chew on. And we're going to remove all of those teeth, but not all at once, because some of those teeth are going to really help me. So what we did is we thought about a transitional approach using teeth. So what I did was, back in the analog day, I prepared teeth on a cast, because those molars, you saw them, they're not going anywhere unless I take them out. She'll take those to the grave unless I remove them. And I've got 2 anterior teeth. The question is, how am I going to build a prosthesis that's going to last 6 months? Well, we just moved into the digital world for that. We placed the implants, but we didn't immediately load it. And what we did was, if I can move this ahead, is we provisionalized this with Trinia, which is a very robust material, a little bit expensive, but we made a substructure in Trinia that was milled, and then we just took a milled methyl methacrylate prosthesis right over it and cemented this into place. And she was able now to have her test drive, if you will. So we put her at a new vertical dimension of occlusion. We gave her central incisors, right? Vertical dimension of occlusion, midline occlusal plane. Her mandible's now in a new place. It moves down, it also moves back. So now I have a better way of thinking about what am I going to do in the lower arch. In the lower arch case was simply all on 4. Now I've got to a point where on your right side, you see the provisional restorations. On the left side, you see how much space I've created, right? I've got my sufficient restorative dimension in both cases. In fact, it's about 14 millimeters in the upper and 15 millimeters in the lower arch. And what I'm able to do with a lot of support from Lee Culp, a dear friend of mine and wonderful technician, is to move from what was in her mouth to a beautifully designed zirconia prosthesis. And think about this, right? We plan this very, very carefully in terms of prosthesis design. If you look, the screw access holes are always in the center of a tooth. Why? Because if you put them in an embrasure, the thickness of zirconia is weaker. That's where they'll break. And angled screw access allows us to do this almost all the time. So why does this case work? Because I didn't sweat the little things, and I made some good choices. The first choice was, I'm making a major change. I want to test drive this. The second choice was, and I didn't tell you the whole story about her being on osteoporosis, having polypharmacy, being at risk for immediate loading, but that was part of it. I didn't want to immediately load this case, so we figured out a way to stage this. How much did that slow me down? Not a lot, right? And the third was, we were able to then proceed to prototypes followed by final prosthesis that really looked like what we envisioned for her at the beginning. Change the midline, change the occlusal plane, change the vertical dimension. Not bad, really. Oh, and by the way, my lesson for the lower jaw to you all is, if you can't see those lower abutments, you can't clean them. There's no speech problem. There's no issue. Just let them shine. And this is what we ended up with for a 72-year-old woman. Very beautiful restoration. She sent me a pineapple plant. Her prosthesis has lasted longer than the pineapple plant. I don't have green thumb, but just a very lovely lady, and just an example of how we make different decisions. And I bring this up to you all because in 2015, I went to Warsaw, Poland, and they asked me to do a hands-on treatment planning class. And I handed out 4 different cases, and I had 24 people, and I broke them into 6 groups of 4. And what I anticipated was 6 groups were going to come up with maybe 3 or 4 different treatment plans. Well, at the end of this, I had everyone present their plan. And in broken English, or very nice English, all 6 groups stood up. No matter what the case was, it was 2 arches, it was all on 4. Every treatment plan resulted in removal of teeth, removal of bone, placement of 4 tilted implants. The world was just, and ever since then, I think, the world has been embracing this idea of this is the only way to treat people with a failing dentition. And one of my messages is that if that's your only choice in treating these people, you're probably making a mistake someplace along the way. This is a patient very dear to my heart. Just before I was leaving Chicago, I was teaching in the graduate program, and I met this patient. And she was a cleft patient who had been treated years ago, not in the United States. And if I go back a slide, you can see she still has an oral antral fistula, but she's got cleft closure. The problem is she's been coming to the dental school almost every other week for someone to reline her maxillary denture, which they haven't figured out how to get retentive. Now, I was confident I could fix that, but I took this as a bully pulpit, and I walked into the director's office because, as you know, in my role at that school, I couldn't make decisions about finances. And I said, this patient has been in the clinic 17 times for a reline. You've already lost a fortune. So why don't we just treat her for free? And he said, what do you mean? I said, well, not for free. I'll get you free implants and I'll get someone to mill a bar, but we're going to treat her with implants because you can't keep relining her denture. Well, I took final impressions of the upper jaw, and I took an impression of the lower jaw. There are lots of things wrong with her plane of occlusion and her anterior crowns, but she can't afford to do anything about them. They're stable. So after taking a centrical relation record, I immediately went from analog to digital. And what we did was we worked with Mr. Culp to design a dentition. And I made a printed denture prototype. And the denture came back, we put it in the mouth, and we realized we'd done what we said we were going to do. Vertical dimension of occlusion, midline, occlusal plane, centric relation record. Got it all. Now, you might think it's all downhill from there, but if you go back a few slides, maybe you remember what that Panorex looked like. Getting this right, she's really happy. Now, it turns out I'm not able to deliver this really robust dynamic display of teeth, and I'll explain why later, but she's really happy. And so because we had that design, I asked Mr. Culp to please print me a duplicate, to which I put some SureMarks stickers on, and we were able to then do a dual scan. Really easy, 5 minutes work. I import this into planning software, and now becomes the challenge. Because her anatomy is not going to allow me to do any of what you've seen before, right? When we look around at this case, I don't know if I can show you, but it's pretty amazing, right? I've got to use pterygoid bone here. And I'm a little concerned. I mean, thank God this is going to be guided surgery because this is the first pterygoid implant I've ever placed. I'm maybe going to get this 3.6 millimeter implant in that really narrow space under the second premolar. I'm going to put a 4.8 millimeter implant in the globulomaxillary area and hope that I find some native bone. Because everything here has been grafted with hydroxyapatite. Let's hope it bleeds when I drill through it. I've got the same problem in the central, and then on the patient's left side, I've got a sinus, and finally I can place a tilted implant. So as a prosthodontist, I'm laughing. I've got implants tilted in opposite directions, going every direction, and I've got to figure out how to get this done surgically, but also restoratively. But you can see I'm remarkably lazy. I'm not going to create a lot of work for myself. I'm going to make sure that I know that my screw accesses are really easy to reach. You heard Dr. Lamar lament about tilting and why we use them. Most of these, the only angled abutment we're going to use is on this implant. So have I achieved my goals? What am I doing about display? I fixed that by making my provisional. Density. Well, let me go back here. Density. Well, I got terrible bone and I got hydroxyapatite. I'm trying to use the largest implants possible with creating viable bone around them. Dimension. I've gotten the most distribution in an anterior posterior position that I possibly can by using that pterygoid implant on the other one side and tilting an implant on the other. And in terms of dimension, well, biggest implants I could. This is what it looks like. And we're kind of laughing at each other when we were looking at this case. I was working with a resident, and I remember her saying, how are you going to put those in? And the answer was, thank God we've got guided surgery because I have no idea how we're going to deliver this. So we go to 3Shape software now, and we import the scan so we know where the teeth are. We duplicate the design. We print a guide. We go to the mouth. And now it's easy. We spent all of our time doing the design. Verify my conversion prosthesis. We make these conversion prostheses just like this. You can see the little outriggers that help it stabilize. We do the same thing in the mandible, so my conversions take 30 minutes. I just pop these off, pick it up, cut it off. Notice again, no flanges, and away we go. No ovate pontics, no concave areas, perfectly flat intaglio surface, highly polished. The tissue will adapt to it. It'll be perfectly flat when you're done, which means it's going to be easily cleansable. And she goes home. Man, is this lady happy. I mean, this is the happiest woman on the planet. Can you imagine 17 reline appointments over a year and ending up with this? And we achieved our goal. We got the implants where they belonged. She comes back. She's healed. We've got lots of limitations here. We've broken my cardinal rule of always having keratinized tissue around these implants because number one, she couldn't afford the free gingival grafts, and number two, there was no tissue to move. And number three, I couldn't get an oral surgeon willing to lift the graft off that maxilla, and I don't blame them. So we go to the framework design, and today with CAD/CAM and design, we can actually dial it in, get a great framework. And then in this case, to finish it, we just milled a PMMA superstructure and adhered it to the framework so we could deliver it. Well, What about zirconia? More expensive. Greater strength? Maybe. More aesthetic? Not really. Possibly a better response regarding biofilm, but finances drove us to this simple solution. Very, very highly polished intaglio surface, one monolithic piece of zirconia, no more teeth popping out of anything. No flanges. And this is what it looks like when it's delivered. It's a very different approach to what you might have thought we were headed to, but we achieved all of our goals in the short term. Not the same dynamic smile we had before because that big metal bar prevented us from doing that. But she really loved the smile. She really loved the teeth. And I think we did a great job for her. We maintained the midline, the vertical dimension, the occlusal plane. So what are my therapeutic goals? Technical excellence, longevity of therapy, which we haven't spoken about, and the patient's therapeutic journey. The case I showed you before was done in 4 clinical visits. That's a great therapeutic journey, right? Diagnosis, surgery, impression, delivery. That's the way it can work. Now, one of the biggest challenges we have with longevity is controlling implant therapy-related inflammation. I've talked about the idea of no flanges, execute better surgeries, keratinized tissue and bone support, build better prostheses. I've talked about no flanges. We've talked earlier about implant design, but we have to recognize the effect of chronologic and biological time on the systemic inflammatory response. The longer you have inflammation smoldering, the longer you're going to have, the greater the problems are going to be. You are actually biologically turning fibroblasts into inflammatory cells. They are going to start pumping out inflammatory mediators, not what they were designed to do. So this idea of a therapeutic journey, you diagnose disease, you tell the patient you can fix it, the patient smiles. You reconstruct them, they smile even bigger, they hug you, they tell you you're the most wonderful person in the world until there's a complication. So you repair it. You push the real problem down the road. Why did it break? Poor design. Why is it failing? Bad biology. And then they have recurrent disease. And what happens? Intervention would be removal of an implant. And now we have failure in a disappointed and angry patient. If you've not done this long enough, you haven't had this happen in your practice, but it happens. So what could it look like? A lot of decisions had to be made here. This patient was referred to me years ago. She has no roots. So we go through the process of design before we had CAD/CAM, anything. We did this case 16, 18 years ago. And it was the first case I'd ever done with Lee Culp, and it was baptism by fire. He said, "Are you kidding me? Is this what you want me to do? You want me to make all these single crowns on implants as the first case we've ever done together? Wait till you see the outcome 16 years later." So we get the case done. I don't have the time to go through the procedures, but you'll see radiographically where we ended up. It's a really nice case. We thought long and hard about what to do. Today, someone take a knee-jerk response to an all-on-4 case for this person, and it's not what this person needs, right? We go from here to here. She's happy. She's 2 years into college. I'm not so sure I'd place all those implants today, but I'm not so sure why I wouldn't, right? And her therapeutic journey was great. By the way, treat college students. They come for an appointment, and you don't see them till the end of the semester. And they come in for an appointment, and you do something, and you don't see them till the end of the semester. They're wonderful. So we get the case done. Technically, we've achieved our goal, right? Therapeutic success. 5 years later, I see her, and things are holding up pretty well. So I moved from North Carolina to become the Dean for Research at Illinois. And in 2018, 2019, I receive a phone call. "Hi, it's Laura." "Laura who?" "Laura, your implant patient, your famous implant patient." Why is she famous? Because I was at a conference in London when her medical insurance company called me, and I was able to convince a medical insurance company, because she had a genetic defect, to pay for this. I think it's the one time it's only and will ever happen. So that's why, and she knows the story, and that's why she calls herself her famous implant patient. So she comes back in, and this was in 2019, so we can fast forward. I've seen her once before I left in 22. She has a little problem. But you know what? That's a 15-year-old problem. That implant was placed facial and alveolar bone. What were we going to do? The answer was we're going to watch it. We've watched it. She has mucosal integration. She has no bone on the facial aspect of that implant. She has no infection. Treat it. Don't fix what's not broken. Here we are 15 or 16 years later. But take a look. She's got tissue around all those implants. She still has papilla between those implants. Right? Aldo was talking about this earlier. The principles in this implant system don't differ from what Ollie's been trying to tell you about, what Jordan's been trying to tell you about, what David's been trying to tell you about. You have to have a good implant-bone interface. You have to have an implant that loves bone. You have to be able to do the work well. And it wasn't perfect. See the soft tissue complication here? Why? The implant abutment interface was loose. What did I do? I didn't cut the crown off. I told her I would remove the crown from the abutment. So I took a serrated forceps that we used to remove a root tip and some rubber dam, and I pulled that crown off. There's only cement. I'm stronger than cement some days. And we removed that abutment, and we tightened the screw, and we put the crown back on. Now, if I wasn't brave enough to do that, I would have cut that crown off. I would have made an impression. I'd have had her come back in. But success is measured by the patient's perception of a therapeutic journey. She loves me, right? And here we are. We take a look at where the problems were at 15 years. Okay, this is the loose abutment, and we got bone loss. There's cement on that cemented crown. We removed it. Too bad I didn't see it sooner, right? And here, some bone loss. Maybe there was cement there. We don't know, but we're talking about 15, 16, 17 years out. You know what's scary? She's in her 30s. What happens to this young lady when she's in her 50s? What I explained to her is she needs to come to the dentist every 3 months for a professional prophylaxis, and she needs radiographs at least once a year. Because I think her therapeutic journey can be very positive. So a therapeutic journey can begin with an intervention, it can end with a reconstruction, and you can never see the patient again. Or there can be a complication, and you can repair it. And if you're on top of things, you can control disease so that the intervention is successful, and the modification, in this case, simple, removing a crown and tightening the abutment, ends up in a positive resolution. So the therapeutic journey is positive. The maxilla is a really nasty place to work, but it's where we spend a lot of our time, and it's where our work shows up in the community. So I have to tell you, implants must provide function and health for a period of time, but we do not know how long that period of time is. Mike Block had a very funny comment about the period of time to now and to then, and he didn't know quite what that distance was. When I lecture to people, I ask, and I'll ask you, how many of you in your room have seen a 40-year-old dental implant? Raise your hands. Great. So, folks in the room, how many of you have treated a patient with dental implants who's between the ages of 30 and 35? Raise your hand. You don't know what the hell you're doing, and neither do I, because those people will live longer than 40 years, and no one has written the book on a 40-year-old dental implant. So what's the solution? Make really good choices. Make really good choices. With that, thanks very much. It's been a pleasure.